everybody, welcome to tonight's Tutor to You revision session. We're having a revision blast on psychopathology tonight, one of your paper one topics. I'm Laura, we're joined once again by Laura and Melissa, and we've just been talking. You have, I think someone's mentioned it in the chat as well, you've got about 24 days to your exams, although, as Laura's just pointed out to me earlier, that includes today and the day of your exams, so maybe slightly less than 24 hours. 24 days, oh my gosh, don't nobody panic. But still plenty of time for you to get lots of revision in, including tonight. We're going to kick off with psychopathology. Who's starting us off tonight, guys?
Mel's starting off tonight.
Yeah.
All right,
Just
Melissa.
unmute myself. Yeah, I'm going first tonight.
Okay, when you're ready.
Wonderful. Okay, so we're going to just start with a quick fire game just to get you warmed up. Hopefully these are quite easy. Missing vowels. So some of these terms you're going to see here, or all of these terms, are relevant to your psychopathology specification. So what is this first one? What vowels are missing and what words would this make up? Okay, influx of comments coming in. Sophie Spriggs, I think you were first with that one. Well done. If you said serotonin, yes, definitely one of the neurochemicals that we need to talk about. We look at that particularly with dopamine, and we look at that with your genes and OCD. Okay, let's have a little look at the next one. What have we got here? Okay, Ellie, I think you were super fast on that one. Well done. There's loads of good answers coming in now. Yeah, polygenic or polygenetic if you wanted to spread it out a little bit. I'm just intrigued very quickly if anyone can tell me in the chat, what does that mean if something is polygenic? Where might we bring that in as well into our exam? So what does it mean and where might it be relevant? Affected by many genes, multiple genes. Yeah, excellent. Some really good answers came in quick there. Yeah, and we could talk about it in OCD, definitely. We could talk about it in some later modules if anyone does schizophrenia or maybe some of the other topics. But yeah, definitely for paper one, OCD is going to be relevant. All right, let's have a little look at the next one. What have we got here? So we add those missing vowels in. What have we got? Lovely. Let me see who that first one was. I get all your answers in one go. There's loads came in at the same time there. I'm going to say the first one I can see is Alyssa, but I think there might be one more before that. JT Galaxy, Rachel Armstrong. Well done, Rachel. Always fast on these. Yeah, so we've got negative triad. Who came up with this idea? Oh, there we go. Someone's got it. Blossom in the chat. We've got Beck's negative triad. Well done. Sophia as well with Beck's theory. All right, let's have a little look at the next one. Maybe a little bit more of a harder one, this one. So I'm looking for what is it first, and then we'll consider what it means. TBK, well done if it was you first, sorry. Lovely, okay. I can see a lot of reciprocal inhibitions coming in all at once there. Who was the fastest? I think AR, you were the fastest on this one. What does this one mean then? Where might we talk about reciprocal inhibition? Where would we bring this one into our paper one exam? Good, Anna. So we cannot be relaxed and we cannot be anxious at the same time. Where do we need to know that for? Yeah, a few people saying, what does it mean? So this idea of reciprocal inhibition is when we're talking about two emotions that cannot be felt at the same time. We can't have a relaxed sense of I guess, mental state, and we also can't be really, really stressed at the same time. So yeah, we might talk about it in our treatment, systematic desensitization, the idea that as we move up that hierarchy, the anxiety hierarchy we've created, that actually you start to reduce in your stress and you start to feel a little bit more settled. And we've got basically these two emotions appearing at the opposite end of the extreme. We can't have them both at the same time. So once you feel fully settled and fully relaxed in that state, you're able to move up to the next level. All right, lovely. Let's have a little look at the next one. Okay, this is our last one of this one to warm us up. So what is this one all about? Well, Done, Rach. Counter conditioning. Well done, Lena, saying counter conditioning. Let's have a little look then at this last one. Wonderful. So counter conditioning, we'll go through this one a little bit later in a bit more detail. So just in case anyone is wondering, what does this one mean? Essentially the idea that if we can condition a phobia into someone, like the behaviour suggests, then we should be able to counter condition that phobia. We should be able to technically unlearn it and try and drive that phobia out of someone. Okay, so I'm going to pass you over to Laura for our next activity now.
Great, thanks, Mel. So we've got 3, 2, 1 game now. You're going to have 2 minutes to answer these following questions. So what we would like from you this evening is 3 behavioural characteristics of phobias. So I want 3 behavioural characteristics of phobias. Then I want 2 cognitive characteristics of depression. And lastly, 1 brain region implicating OCD. And if we can try and input all of our answers at the same time as opposed to doing the first one, the second one, and the last one, that'd be great. So you've got 2 minutes, guys. Time starts now.
5, 4, 3, 2, 1. Five, 4, 3, 2, 1.
Okay, some really good answers that have come through and really hard to keep up with you all. From what I can see here, we're all got very similar answers for the 3 behavioural characteristics of phobias and the cognitive characteristics of depression, which is really great to see. Some different brain regions also came up. But I think the important thing to stress here with behavioural and cognitive is the difference between them. Now, if you were going to define the difference between a behavioural and a cognitive characteristic, how would you define it? Can anyone tell me? What makes something behavioural, what makes something cognitive? Because there were a couple of answers I did see where someone had listed a cognitive characteristic for the behavioural characteristic of phobia. So how would you guys define that difference? How do you know it's behavioural versus cognitive? Yeah, so behavioural is maybe more the action, the way we behave, the way we act. Someone's put cognitive is to do with our thinking. Yeah, so our thought process is really great. And that's a really nice distinction to make sure that you guys have clear cut so that you can make sure that you're picking out those correct characteristics, be it emotional, behavioural, cognitive. So let's reveal the answers, guys, for number 3. So we've got 3 behavioural characteristics of phobias. Here we've got avoidance, freeze, fight or flight. A lot of you put quite a few of those down, so it's really encouraging to see. For number 2, we've got 2 cognitive characteristics of depression. So again, a lot of you put down about the irrational negative thoughts. And again, we can bring back in here the negative view of the world. And then our last one for a brain region, a lot of you put the basal ganglia, which is also fine. We've put the OFC, the orbital frontal cortex, and you've also got the caudate nucleus there that kind of impacts that worry circuit. So a lot of you put those brain regions down, so that was really great to see. We're going to play one more 3, 2, 1 game on slightly different area of psychopathology now. So again, you're going to have 2 minutes. So we've got 3 ideal mental health criteria, 2 limitations of statistical infrequency definition of abnormality, and then lastly 1 limitation of the failure to function adequately definition. So you got 2 minutes, guys. The more elaborate, the better.
5, 4, 3, 2, 1. 5, 4, 3, 2, 1.
Wow, some really good answers coming through, especially when it comes to the evaluation of those definitions. So let's have a look at the third one. So ideal mental health criteria. It's good to kind of know a couple of these for examples. It's not something you need to learn strictly as a list, but it's nice to be aware of them. So we've got personal autonomy, environmental mastery, accurate perception of reality, and quite a few of you named quite a lot of the others that were there on that Jehoda's list. So that's really, really great to see. For number 2 then, so we've got limitations of the statistical infrequency definition. I've just highlighted an answer by Richard and Zara, and they've put some abnormal behaviours are common, but some things which are rare are actually desirable, and they've given the example there of a high IQ, which I can see a couple other students have also done. So really great there to demonstrate your point with an example there. So we've got, it doesn't account for desirable and rare behaviours, which is the same as yours. And then lastly, we've got some mental health conditions would not be statistically rare. Can anybody give me an example of what I mean by that? Some mental health conditions would not be statistically rare today. What might that be that a lot of people might arguably suffer with in their lifetime? Okay, yeah, so who got in there first? I think that was EA, yeah, depression, well done. Yeah, so again, it's quite common. It's not statistically rare anymore. Yeah, so really good. And then our last one then, we had a limitation of failure to function adequately. I can see quite a few of you put about the culture bias. We've got here, not everyone who needs intervention will experience distress. There's quite a variety of answers here, but a lot of you did come up with the culture bias point. Different cultures are going to have obviously different social norms, expectations of what maybe functioning adequately might mean to them. So yeah, you could definitely apply that point there. Really good. Okay, I'm going to pass you over to Mel now for some evaluation.
Okay, thanks, Laura. Yeah, they were brilliant answers there, guys. I was just following the chat coming through, so really well done. We're going to stick with this topic now of definitions of abnormality, and I think Laura and Laura will both agree that this seems to be a topic within psychopathology that people often forget actually exists. People go straight into phobias and OCD and depression and forget that right at the beginning of all of that is how do we actually define what mental ill health looks like? How do we decide if someone is suffering from something like depression or anxiety even once they're on your spec? So we've got 4 definitions of abnormality, which we've just spoke a little bit about now. We're going to stick with one of those, And if you've done these lives with us before, you will recognize this task of chains of analysis. So you're going to see some sentences pop up on the screen for us. And essentially what we're doing here is evaluating one of your definitions. We're going to stick with the issue with statistical infrequency, one of the problems with it. All I want you to do is work out what order should these come in to form that perfect evaluation or analysis paragraph. So also what you should do is pop these into the correct order. You don't need to type them out. You can just put the numbers. So look for that first sentence that you might start your paragraph with when we're introducing one of the problems we spoke about, and then how would your chain of analysis continue from there? Okay, wonderful. Lots of good answers coming in here. Most of you look like you're on the correct line. Some of you have got some just a little bit slightly out of order, but we'll address that now. I think Lois was the first person to get that in, but let's have a little look at what we've got. So what order we're going to go with here. Okay, so we're going to stick with this idea that with statistical infrequency, it can be argued that there is arguably this degree of inflexibility with the definition in terms of how we apply it. Now we need to continue with that point. So we've stated our initial point, that the problem or the issue. Why? Well, it states that scores in the top and bottom 2.5% of the population are abnormal. Well, why is this a problem? So we need to expand on this and analyse this further. Some behaviour which is deemed abnormal by the diagnostic manuals for mental illness that would not fit in with that definition. So, for example, 3% of the population is thought to suffer from OCD, but some of those individuals may not be seen as abnormal because they're actually within 2 standard deviations of the mean. So this means that the definition and the current criteria for defining mental health issues are at odds with each other. Now, it's this last sentence when we're analysing that I think a lot of students, if you're like mine, are still struggling with this so what at the end. This is sort of the crux of it. It's what turns your knowledge into an AO3 evaluation analysis point. If we just did the first point, second, third, and fourth, and we left that last sentence out, all you're really doing is showing us some AO1 knowledge. But in order to turn it into this evaluation point, we really have to come in with that justification sentence at the bottom and expand on that further. Okay, let's have a look at another one of these. So again, sticking with the same idea, but this time we're going to go with deviation from social norms as a definition. So all I want you to do is think about where are we going to go with the order of this chains of analysis sentence. I'm sorry, I am trying to follow the chat at the same time as reading the screen, so I'll see if I can find any questions. Yeah, Elsie, I can see you saying I need it on paper, otherwise I'm lost. That's absolutely fine. Remember, these videos are available for you to go back through, so you can have a go at writing them down properly. Okay, loads of answers coming in now. I want to say Ellie and India and TVK were the first ones. Let's have a little look. So some of you got them correct. Okay, wonderful. So have a little look at the numbers you put in the order. Did you get them in the same order that we've got? So again, we've got this introduction point sentence where we're going to say one of the problems or one of the issues with the deviation from social norms definition of abnormality is the idea of cultural relativism, and therefore the inability to use this definition globally. Now, what we often see in evaluation is a lot of people just stop there. It's a bit like a shopping list. They'll just stop there and say, here we go, this is the issue. But we need to actually explain that a little bit more. We need to take that analysis further. So what does this mean? So we could go on to say that social norms differ between cultures, and what is considered normal in one culture may be abnormal in another. Now, again, a lot of people sort of stop there and they don't give us an example. So they don't tell us, what is one of these behaviours that in the UK we might accept and we might say is normal. But if you go to another country, they might say it's completely abnormal. So here we're going to bring in an example. So, for example, in approximately 75 countries in the world, homosexuality is still illegal and therefore it's considered abnormal. It's really, really good to have an example. Whatever example you go for, make sure you're able to embed it into this deviation from social norms. Then we're going to tell, well, why is that a problem? However, in the rest of the world, homosexuality is actually considered normal. Now, again, if you stop there, all you're really doing is showing us some knowledge. So we've got to turn that into an evaluation point, and it's this last sentence at the end. The result of this is that there isn't actually a global standard for defining behaviour as abnormal, and therefore abnormality is not standardised. I'm intrigued, just while we're doing a bit of research methods check, can anyone tell me what that word standardised means in the chat? If we're saying something isn't standardised. Yes, someone's saying, Toulouse saying, could you add temporal validity in the link? Yeah, you could argue that norms have changed over time. And yes, keeping the same procedure, kept the same. Excellent. We can't have the same definition which is applied across all cultures. So this is just something to be aware of. Remember, you can have an essay on your definitions of abnormality. That would not be uncommon at all. So it's really worth having some of these AO3 points that you're ready to go with for each of your definitions. That was super work, guys. I'm going to pass you back over to Laura now for our next activity.
All right, so this next game then, we've got to work out the 4 groups of phrases here, okay? And what's really important, once you think you've grouped a common 4 phrases in that diagram, put your answer into the chat box and tell me what you think the commonality is between those 4 phrases that you've picked out. And that's going to occur 4 times here in this diagram, okay? So let's see who gets the first 4 grouping and the label of that grouping, what it means. So I think Millie, I can see you've got one of the groupings there. Oh, your name's gone because everyone's been so quick. Yeah, so you said Jehoda. So yeah, ideal deviation from ideal mental health. Excellent. That's one grouping definitely. And then we've got JT Galaxy, we've got cert gene, comp gene, caudate nucleus, orbital frontal cortex. Biological explanation for OCD. Well done, JT Galaxy. Yep, you're correct in saying that. Let's see if we've got any other of the... Yeah, so we've got behavioural, Caro, behavioural activation, accurate view of yourself, homework, goal setting. Yeah, CBT, tasks and CBT. Excellent. And I think there's only one more to get, which I think I've already seen you guys have got, which is our first one we're going to go through. I can't see if anyone's actually got that one. Let's go through the first grouping that we've got. So the first grouping we've got, sorry, the OCD explanation, someone did get that. So we've got our comp, orbital frontal cortex, caudate nucleus. They are all explanations, biological explanations of OCD. And then our second grouping, I think, was the one that I didn't quite see. So this is phobia researchers and concepts. So don't forget, we've got our Watson and Rayner, the Maurer one, generalized and conditioning as well. Okay, so there are phobia concepts when we're talking about explaining, if you like, phobias. Our next one then is CBT. So here we've got goal setting, homework, disputing, behavioural activation. Can anyone tell me the 3 names for the 3 types of disputing in the chat box? Has anyone been through those 3 types of disputing? What are they called? Yeah, we've got empirical, logical, Yazin, well done. Yeah. Yeah, so again, this is just a method, a way, if you like, yeah, lots of answers coming through now, pragmatic as well, excellent. A way of challenging those irrational negative thoughts, if you like. So, and our last group here is our deviation from ideal mental health criteria, which I think quite a few of you got. This was quite a long one to write out, wasn't it? So capable of personal growth and self-actualization, obviously a positive view of the self, then accurate view of reality, and being autonomous and self-regulating as well, okay? So I'm going to pass you over to Mel now for the 30-second challenge.
Okay, so this one is going to move quite fast, as it is saying that it's a 30-second challenge. So all I want from you is enough information as you can possibly type about each of the questions in 30 seconds and send it over. First one, explain the true process model. What might you pop in here? Yeah, wonderful. Well done. I'm just having a little look at who came through first on mine. Apologies if I've got this the wrong order. First one I can see is Harrison. We've also got Lola giving us some answers there, JB. Let's have a little look at what our answer is. Good. So a lot of you said this idea that we acquire or that we learn phobias through association. That's the first part of the process involved according to behaviourists. So that's the classical conditioning. And we maintain them through negative reinforcement, that operant conditioning. A lot of people struggle with that idea of the second part. Remember, if you are avoiding your phobic stimulus, if you're avoiding the thing that makes you scared, it makes you fearful, you're going to maintain that phobia for a long period of time. Through that negative reinforcement, the anxiety is getting reduced, and that positive feeling then is comes upon you. It's just worth knowing in the exam they could refer to it as outline behaviourist explanation of phobias, but they could name it the two process model, and sometimes it can throw students. They think, what's that? Remember, just think, what are the two processes involved in learning and maintaining a phobia? That's all the question is getting at you for. All right, let's have a little look at the next one. 30 seconds again, so fast typing. Explain which factor in Ellis's ABC model causes depression. Okay, I'm just trying to have a little look here. So a lot of people went for the activating events, but I think the first one I can see that was correct was Emily. So let's have a little look at the answer on this one. Yeah, so it's not actually this activating event that causes that undesirable outcome, the depression. So a lot of people have said that, and you're correct in thinking that that's what the A stands for. But let me just briefly explain this one for you. Anyone can experience these activating events. Let's say your friend walks out of the classroom. That can happen to any of us. And for most of us, if we have a rational belief, if we think rationally, then we might just say, oh, they must have gone to see a teacher, or they must have told me that to get off early. I can't quite remember. It's this part here, though, the B, if you feel irrational. And we don't just mean on the odd occasion, but if we can continuously feel this irrational thought process towards something, towards these different activating events, then the consequence is more likely to be depression. So we really need to focus on that B within the ABC model. You can either think, I can see Amia's just put in there now, you can either think rationally or irrationally. And if you consistently have these irrational beliefs about different activating events within your life, then the consequence is more likely to be depression. Well done, there's some gorgeous answers there. All right, let's do one more. Identify a limitation of using drug therapy to treat OCD. Okay, I can see a lot of people have come up with side effects. I'm just trying to see whether there's anything expanded on. Doesn't address the root cause. Yeah, without scanning through, because we're nearly coming towards the end of our session now, I can't find anyone who's expanded on it a little bit further. If we just show the answer we've got, it's just something I want to just cover very, very quickly. If you're going to talk about side effects of any drug therapy, whether that's in OCD, whether it's schizophrenia, depending on what topics you study, of course, you can just list some of the side effects and say some of the examples of them, such as here we've got indigestion, hallucinations, erection problems, raised blood pressure. However, to take this further, it would be better to say, well, why is that a problem? Of course, a lot of drug treatments can have side effects with them. The main issue is that with these side effects, a lot of people will end up saying, well, I don't want to have indigestion, I don't want to have hallucinations, so I'm going to stop taking the drug. And in doing so, you are stopping the effectiveness of the medication, because you drop out from taking it. So if you're going to go with side effects, that's absolutely fine. But to further analyze it, make sure you say, because of these side effects, people essentially turn around and say, no, not for me, I don't want to take it, and they stop taking the drugs, meaning that it's not effective in any way at all. Wonderful. Okay, so back to Laura very quickly for our last task, and then you guys are done.
Okay, so we've just got 2 questions we're going to decode here and have a very kind of brief discussion in the chat box. So we've got this question: discuss the deviation from social norms definition and the statistical infrequency definition of abnormality. So 60 marks. So can anyone tell me, just looking at this question, what are kind of the key elements of that question that we really need to focus on here? What are the important aspects that we need to draw attention to? Yeah, so we've got discuss Sophia AO1 and AO3, and the big giveaway there also is the fact that it is 16 marks. So yeah, we are having to evaluate, but don't forget we are outlining too, and this is often a misconception with these questions. And again, a lot of the time the giveaway is the fact that it's a 16 marker. With discuss, a lot of students think, oh, that might just be evaluate. It's not. It's the outline and evaluate, especially with regards to this particular question and the amount of marks. So we've got 2 definitions here we're having to discuss, and obviously our discussion is slightly different from a simple outline and evaluate. We really want to kind of give both sides of the pros and cons, if you like, of both of these definitions in terms of defining abnormality for the 16 marker. All right, let's look at the next question then. So our next question is: explain what is involved in flooding as a treatment of phobias. So what's this question asking us to do? What are the important aspects of this question here? Yeah, so Lena, you've just asked a good question. Does discuss mean both positive and negative? Yeah, generally speaking, the expectation is you're discussing. So you're discussing kind of those sides in terms of explaining a particular behavioural topic. With evaluate, it would be very, common to see students give just 3 weaknesses and no strengths, and that's perfectly fine for an evaluate. With discuss, we might want to be seeing that kind of both those sides, if you like, come into your evaluation. Okay, so we've got obviously explain, developing what the steps are involved. So yeah, this what actually is involved in flooding. So actually explaining those steps. Remember, it's only 3 marks, so we're not looking for like a 6 mark or loads of detail here. And don't forget, and it's often the bit that students miss out here, we do have to contextualize this to phobias. That's really important. That might seem really obvious to you in the exam. You might miss out mentioning anything about phobias, but it's really important you stay on that topic area and make that obvious as well within your answer. Okay, that concludes our evening session, doesn't it?
Yeah, goes by so fast, doesn't it? But some great answers from there. Just noticed in the chat, Elsie has asked 2 questions about comparisons. So the first one earlier was, can we help? Can we give any tips about comparing approaches? We can, and we will go through it, but on our paper 2 exam clinic, where we can give it sufficient time, because we know it's an area that students need help with. And then you've just asked Elsie as well, can you be asked to compare things in psychopathology? No, you won't be asked to do that. You could only outwardly be asked to do that on approaches, but there's nothing stopping you doing that in terms of your evaluation for things like OCD, depression, etc. Right, it's a great session there. Don't forget you can watch this back again, because we've covered lots of content and you've got lots of tips off Melissa and Laura. You can get some revision help from us on Instagram at Tutor2U And important notice, we're normally here on a Tuesday, but next week we're here on Monday at 6 o'clock, and we'll be going over some tricky areas in social influence. So thank you.
Laura, just quickly, I can see a few people asking, when is the exam clinic? Do we know the date of that, if it's paper 1? Have we got a paper 1 exam clinic coming up? Or
yeah,
can we get...
they're all posted on Instagram, but I can tell you our very first exam clinic is Wednesday the 14th of May. So I know we do these once a week, but as it gets closer to your exams, you'll see us a couple of times a week. So we said earlier, you've got about 23, 24 days to your exam, which means you've only got us a handful more times, really. But you will see us for exam clinics for every paper. We've still got lots of topics that we're going to go over. And honestly, we will give you as much help as we can between now and the exams.
Just to also say, sorry, Laura, with those exam clinics, I know some of you were asking this question before, but the exam clinic will be structured in a way where we'll do a normal revision blast for the topic that's advertised, and then the other half will be Q&A. So you can come to those sessions with questions that you might want answered by the team, basically. That's how they'll be structured.
Yeah, a few people saying, what does an exam clinic mean? It just gives you a bit more opportunity to ask those personalised questions, doesn't it, where the team can give you more specific answers if there's niche areas that I guess you're struggling with. So you can come and pop your questions in the chat.
Even if it's, can you give us like 60 seconds on fight or flight, we'll do that. If it's, how would you structure this question, we'll do that. So there's no question that we won't answer about psychology. All right, well, we'll see you next time on Monday for some social influence revision. Until then, thank you very much, Laura and Melissa, and thank you to everyone who's took part. We'll see you next week.
Thank
Thanks.
you.
Bye.
Bye.